Margaret Chen is a 71-year-old retired school librarian from Columbus, Ohio. She has been taking Lisinopril every single morning for 6 years. Her blood pressure numbers look great on paper. Her doctor is pleased, but Margaret is not doing well. She feels dizzy by noon and exhausted by 2 o'clock in the afternoon. She cannot make it through a chapter of the novel she is reading without nodding off. She tells her daughter, "I think I'm just getting old." Her daughter refuses to accept that. She insists on a second opinion. And when the new doctor reviews Margaret's chart, he does not change her diagnosis. He changes her medication. What he discovers shocks both of them. And what happens next is something every single person watching this needs to hear. I'm Dr. William, and if you or someone you love takes Amlodipine, Losartan, or Lisinopril, this video could genuinely change the way you think about your blood pressure treatment. Here is what I have come to believe after years of working with older adults. These 3 medications save lives. That is not in question. However, the way they are prescribed, dosed, and monitored in adults over 65 is often dangerously incomplete. Many side effects experienced by older adults are dismissed as simply part of aging, when in reality, they may be the medications speaking. Today, I am going to walk you through 6 critical things that most patients taking these medications were never told. And I need you to stay with me through all 6 because number 3 is a side effect that millions of people blame on aging when it is actually caused by their medication. And number 5 is a blood pressure reading that may appear perfect on paper, but could actually place you in the hospital. If you take any blood pressure medication, or if someone in your family does, subscribe to this channel right now because what we discuss today could change the conversation you have at your very next doctor's appointment. Before we begin the list, I want to give you a framework, a way of thinking about everything that follows. I call it the dose assumption trap, and it works like this. Pillar 1. Your doctor prescribed your medication based on clinical guidelines. That is entirely appropriate. However, what most people do not realize is that these guidelines were built primarily on studies involving people in their 50s and 60s, not 78-year-olds taking 3 additional medications and living with bodies that process drugs very differently than they did 2 decades ago. Pillar 2. The dose that controls your blood pressure numbers on paper may quietly be creating symptoms that you are attributing to age. Fatigue, dizziness, brain fog, and swollen ankles are not inevitable parts of aging. They may be medication side effects hiding in plain sight. Pillar 3. Controlled blood pressure on your medical chart does not automatically mean optimal blood pressure for your body. A number that looks perfect in your records might actually be making your daily life worse. That is the dose assumption trap. Your numbers look fine, so everyone assumes your medication is fine, and no one asks how you actually feel. Keep this framework in mind as we go through every single item on this list. Number 1. 3 medications, 3 completely different mechanisms, and why it matters which one you are taking. Robert Morales is 68 years old, a retired truck driver from San Antonio, Texas. When his blood pressure came back elevated during a routine physical examination, his doctor handed him a prescription for amlodipine and said, "Take this once a day." Robert asked one question, "What does it do?" His doctor replied, "It lowers your blood pressure." And that was the end of the conversation. Robert took that pill every day for 2 years without understanding a single thing about how it worked or why that particular medication had been chosen for him. And that lack of understanding nearly cost him dearly. Here is what Robert was never told, and what you may not know either. These 3 medications work in completely different ways inside your body. Amlodipine is a calcium channel blocker. It relaxes the muscles and the walls of your blood vessels, allowing them to widen so that blood can flow through with less pressure. Losartan is an angiotensin receptor blocker, or ARB. It blocks a specific hormone that signals your blood vessels to constrict. Lisinopril is an ACE inhibitor. It prevents your body from producing the enzyme responsible for creating that same blood vessel constricting hormone. Why does this matter? Because each of these classes of medications carries a unique set of side effects, drug interactions, and risks that become increasingly significant with age. Knowing which medication you are taking is not trivial, it is essential. So here is your first action step. Ask your doctor this question at your next appointment. Why did you choose this specific medication for me instead of one of the other classes? If you do not receive a clear and specific answer, that is a conversation worth continuing. And it is within these side effect profiles that things begin to get uncomfortable, especially with one of these three medications. Number 2, the side effect your doctor calls normal, that is anything but normal. Linda Hargrove is 73 years old, a former postal worker from Richmond, Virginia. She has been taking amlodipine for 4 years, and for most of those 4 years, her ankles have been swollen. Not just slightly puffy, swollen enough that she stopped wearing the shoes she had worn throughout her entire adult life. She brought it up to her doctor at least twice. Both times the answer was the same. That is a common side effect. It is harmless. Do not worry about it. Linda trusted that answer. She adapted. She purchased wider shoes. She elevated her feet every evening. She accepted the situation until one afternoon when the swelling became so severe that her daughter took her to urgent care, where they discovered that the edema had been masking a deeper circulatory problem that had been developing without proper monitoring for more than a year. This is not rare. The Journal of the American Heart Association has documented that amlodipine-related peripheral edema affects up to 10% of patients, and the incidence increases significantly with advancing age and higher doses. In clinical practice, it is often trivialized. However, the underlying mechanism makes it far more than a cosmetic issue. Calcium channel blockers such as amlodipine dilate the arteries, but they do not dilate the veins at the same rate. This imbalance causes fluid to leak from the capillaries into the surrounding tissues. In younger individuals, the body often compensates for this change. In older adults who may already have reduced venous return, this can create a cascade of problems. Swelling leads to reduced mobility. Reduced mobility leads to further circulatory decline, and further circulatory decline leads to an increased risk of falls. That is not harmless. If you experience swollen ankles while taking blood pressure medication, do not simply accept it. Request a comprehensive medication review. Alternatives do exist. Switching to an ARB, adjusting the dosage, or combining lower doses of 2 different medication classes can often solve the problem. Never accept "it's normal" as the final answer when a side effect is changing the way you live. If you or someone you love has experienced swollen ankles from a blood pressure medication, type "swelling" in the comments right now. I want to hear about your experience. However, amlodipine is not the only medication hiding something. If you are taking lisinopril, what comes next may sound painfully familiar. Number 3, the cough that will not go away and what it is really telling you. James Whitfield is 69 years old, a retired electrician from Knoxville, Tennessee. 3 months after starting lisinopril, James developed a dry, persistent cough. It was not a cold. It was not allergies. It was simply a tickle in the back of his throat that gradually turned into a cough that refused to go away. He visited a pulmonologist. He underwent a chest x-ray. Some nights he even lay awake worrying that he might have lung cancer. For 8 months, not a single doctor he saw asked him one simple question: what medications are you taking? This is not a rare side effect. ACE inhibitor-induced cough affects up to 15% of patients, and some population studies suggest that the number may be even higher. The New England Journal of Medicine has extensively reviewed the mechanism behind this phenomenon. Lisinopril blocks the enzyme responsible for breaking down a substance called bradykinin. When bradykinin accumulates in the lungs, it irritates the airways and triggers a persistent dry cough that no amount of cough medicine will relieve. In older adults, this cough is far more than a minor annoyance. It disrupts sleep. It causes dizziness and lightheadedness during coughing episodes. It increases the risk of falls. And it diminishes quality of life in ways that are difficult to measure, yet impossible to ignore. If you develop a new, unexplained cough after starting an ACE inhibitor, such as lisinopril, inform your doctor immediately. Switching to an ARB, such as Losartan, eliminates this problem in the vast majority of patients. This is a well-known, thoroughly documented, and completely manageable issue. It is not something you should ever be told to simply live with. Now, after hearing all of that, Losartan may sound like the safer option. However, number 4 is the hidden danger that patients taking Losartan specifically need to understand. Number 4, the silent potassium problem that no one is monitoring. I am not going to share a single patient story for this one because hospital data tells a story that is far more concerning than any individual case. Both ARBs, such as Losartan, and ACE inhibitors, such as lisinopril, have a well-documented effect that receives far too little attention during routine medical care. They can increase potassium levels in the blood. The medical term for this condition is hyperkalemia. Data published in the American Journal of Kidney Diseases shows that hospitalizations related to hyperkalemia among older adults taking these classes of medications are alarmingly common and continue to rise. Here's how it happens. These medications reduce the activity of a hormone called aldosterone. Aldosterone sends signals to the kidneys, instructing them to eliminate excess potassium. Less aldosterone means less potassium leaves the body. Now consider the realities of aging. Kidney function naturally declines as we grow older, meaning that the kidneys become less efficient at removing potassium from the bloodstream. Then consider what many older adults are eating. Bananas, spinach, potatoes, sweet potatoes, and beans, all widely promoted as heart-healthy foods and all extremely rich in potassium. Next, add potassium-containing supplements or salt substitutes, which many health-conscious adults use without giving them a second thought. The accumulation of potassium can eventually become dangerous. And here is the part that scares me most. Hyperkalemia often presents with no symptoms at all until it triggers a cardiac arrhythmia, a potentially fatal heart rhythm disturbance with no warning. What to do instead? If you are on Losartan, lisinopril, or any medication in the ARB or ACE inhibitor class, you need your potassium levels and kidney function checked regularly, at minimum every 6 months. This is not optional. It is essential monitoring that too many patients are not receiving. At your next appointment, ask one question. When was my potassium last checked? If no one can give you a clear answer, that is a problem. If you've been on one of these medications for more than a year and have never had your potassium levels tested, type never in the comments. I think you'll be surprised how many of us are in the exact same situation. But here's the one that scares me the most as a physician, and it's the one that almost no one is talking about openly. Number 5, the blood pressure number that's actually too low when your medication becomes the danger. Dorothy Flanagan is 76, a retired teacher's aide from Scranton, Pennsylvania. Her blood pressure was what her doctor called perfectly controlled, 118/70. Every visit, her doctor smiled and said, "Numbers look great, Dorothy," and Dorothy smiled back. But Dorothy was falling, twice in the kitchen, once in the driveway where she scraped both palms on the concrete, trying to catch herself. And then one Tuesday morning, her daughter found her on the bathroom floor. She had stood up, the room went black, and she went down. The emergency room diagnosis was orthostatic hypotension. Her blood pressure was plummeting every single time she stood up. The medication that was supposed to protect her heart was putting her bones and her brain directly at risk. The data on this is compelling and growing. Follow-up analysis of the landmark SPRINT